Great Lakes Addiction Technology Transfer Center. We are located at UW-Madison in Wisconsin, and we serve Health and Human Services Region 5, which includes states of Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. And we are funded by SAMHSA, the Substance Abuse and Mental Health Service Administration, to help people and organizations implement effective practices for substance use disorder treatment and recovery services. I will put a link to the Great Lakes ATTC in the chat. On there, you can find our upcoming events with our calendar. You can register for trainings. We also have a listing of products, which include previously recorded webinars, one-pagers, fact sheets, those types of things. So lots of good information on there. I want to say thanks to all the folks at AHP today for having us and working with us today for this PPW webinar series. So with that, I will hand it over to Deb.
Great. Thank you so much, Jean, for the introduction and for all of your support in doing this webinar series. Today is the second of a three-part webinar series, and we're focusing on updates on pregnancy, alcohol use, and FASD. We're gonna do this session a little bit different than other sessions. So it's not going to be like a traditional webinar, but it's also not going to go all the way to being like a talk show. I'm calling it a hybrid model to see how that works, where we're going to have some presentations and some also panel conversations. We have opportunities for you all to interact using some combination of polls, and we really want to also engage in conversation using the chat. So as we're getting started with this, I want to take a moment and invite all of you to say who you are and your why. Like, what brings you to this webinar? What is so important to you about pregnancy, alcohol use, and FASD? And then I'm also going to invite each of our three speakers for today to tell you a little bit about themselves and what draws them to this work, why it's so important. So let me first invite Candice Russell to introduce herself.
Hi, good morning or afternoon, everyone. My name is Candice Russell, and I am a senior program associate here at Advocates for Human Potential. And I feel that one of the biggest reasons I care a lot about this population, as well as coming to this webinar, is I really want to help build capacity for providers that they make sure they are actually working with the pregnant or postpartum women population. I feel like there's a lot of this population that doesn't get put into treatment or get brought into treatment, and that they absolutely get missed. And so, especially when it comes to alcohol, there's so much stigma that continues to impact this population, especially in BIPOC communities. And I come from a lens of really building equity into our field of treatment. So I think that is my biggest why, is making sure that we are really prepping our services to kind of care for this population, and particularly those who do miss coming in and out of treatment. So I think that would be my why.
Great. Thank you so much, Candice. And now let me introduce Kathleen West. Dr. Kathleen West, can you tell us a little bit about what brings you to FASD world?
Sure. Thanks, Deb. And thank you, Candice. That's definitely, I think we're all here because we really care about trying to communicate about this. But my background is in epidemiology, which is looking at epidemics. And my area has been reproductive epidemiology, so areas of problems. And I worked at Martin Luther King Hospital in the 80s and 90s. I've been around this field for a long time. And at the time, the issue really was cocaine, crack cocaine in pregnant women. And I knew very little about fetal alcohol spectrum disorder, the whole thing. It was not something that was taught very much. And I began learning about it just through my work with women who were using illicit substances. They were typically using alcohol as well. And then in 1992, I was asked to be an expert witness for a death penalty case in California, the execution of Robert Alton Harris, who had killed 2 teenage boys in San Diego at a Burger King, and then killed them, then took their hamburgers and went and sat in the car and ate them. And he was arrested with his brother. And he was an adult fetal alcohol syndrome person. He had FAS that was undiagnosed, for a very long time, but he had had a long history of foster care. His mother died at age whatever when he was about 7. He was the first one in 25 years, and it was his IQ was about 65, and it was a really disturbing experience for me. Obviously, my expert witness testimony didn't really help. He was the first person to die in the gas chamber at San Quentin, and after 25 years of not having executions in California. So it just became apparent to me that this obviously has lifelong consequences for people, and the failure for him to be well treated was really disturbing. So I've continued to be involved in this issue for a long time. Thank you, Deb. I know that's a long introduction. Sorry about that.
Definitely no need to apologize, because I think, what brings you all to this work is part of what makes this for such a rich conversation, because we're going to present a lot of data and facts to you, but also some of that passion and that lived experience is really key to making a difference with this population. And with that, let me introduce Sarah Farmer. Sarah, can you come up and introduce yourself?
Yeah.
Yes, thank you. I'm an communications manager here at AHP, but in addition to working in the health and behavioral health field for about 25 years, I've been raising a daughter with FASD by myself for the last 23 years. So my introduction's a little longer because I wanted to give you a little of what the lived experience is, what it's like to actually have this be your daily life. That first picture there is the first day that I adopted her. And as you can see, she doesn't have the facial features really of FASD. When I adopted her, they told me she had perfectly normal development. So I was expecting a fabulous bonding experience with this great kid. But within a week of having her home, I knew something was seriously wrong, but I didn't know what. So I took her to countless of the top professionals in Boston and DC, because I was working for Harvard Medical School at the time and had incredible access. But no one could figure out the cause of her incredibly complex behaviors, the memory issues, cognitive delays, confusion, physical ailments, processing issues. There was just so much, major mood issues and rages. And she started having suicidal ideations at age 7 and called herself the dumb girl, because she didn't understand what was happening anywhere in her life, and she didn't know why. And I didn't know why. And I felt like the worst mother on the planet. And like I never should have adopted this child because I couldn't parent her. And it wasn't until I took her to one of the top neurologists, or the neuropsychologists in the world, who works only with adopted children. And that was when she was diagnosed with FASD. And that was not until age 11. But finally, I had a reason that I could wrap my head around. And then a few years later, I found out through an investigator that the birth mother had actually tried to abort her by excessive alcohol. So the diagnosis was correct. But raising her has been the single most difficult and beautiful experience of my life. Raising a child with FASD, whether it's mild, moderate, or severe, is incredibly difficult. It's a 24/7 caregiving role that will last until she dies or I die. And she needs supervision 24/7, or else really bad things happen, like drug overdoses, running away from home, self-harm. It's just scary. And in the beginning, I was blamed for being a bad parent, for not being strict enough, for not pushing her hard enough, by schools, by other parents, by therapists, even by my own family. Getting a diagnosis is so important, because that was the validation for me that I wasn't a terrible mother and that she wasn't a terrible kid. She just had lifelong brain damage that we had to adapt to. And those pictures are of her now. The one in the middle is her when she's in a better mood. The one on the right is her in the psych ward when I had to take her the first time, which broke my heart. But these kids often, and especially as they become adults, need inpatient care. And in the more than 23 years that I've had her, will be 24 years this year, we have seen literally hundreds of mental health and physical health providers. She's had more than 30 emergency room visits and had multiple inpatient stays for up to 3 months at a time. And in those 23 years of hundreds of professionals, 2 have understood FASD. 2 out of hundreds. And this is why this is so important to me, because our nation, our world is full of people with fetal alcohol spectrum disorder, and people don't know it. And they don't understand the secondary characteristics, the way medicine is metabolized, the impact on mental health and brain development, and not to mention the incredible toll it has on parents and family. Just so you know, up to 70% of children in foster care have FASD, because not necessarily, some of them may be parents that aren't fit, but other times there were moments when I thought I couldn't even handle this, and I've got a full background in it. And it's pushed me to the very breaking point. Caring for a child and an adult child, because you care for them, again, until they're dead, it's a lifelong commitment, and it's utterly exhausting, and usual parenting techniques do not work. These children and adults are not like other people, and the parents aren't bad parents. They're confused, they're exhausted, and they have no idea how their child's brain works or why they act so differently from other children. And the teachers don't know, the therapists don't know. And I'm a part of a community of more than 7,000 parents of children with FASD and also people with FASD. And in those chats, the pain and the hopelessness is just palpable. So many of them looked and act typical enough that people expect them to behave typically. And when they don't, it's so much harder. It's like invisible disabilities. If they looked, and some of them that look different maybe get more sympathy. Those like my daughter, people expect her to act like every other 27-year-old, and she simply can't. Mentally, she's about 7. And so I'm here both as a health professional and just to give you a reality check about what life is really like when you're raising a child with FASD. And I thank you so much for being here, because without professionals to help us, we can't carry on.
Thank you so much, Sarah. And my heart goes out to you. I really appreciate you coming on and sharing some of your experience. One of the things, because I've had the opportunity to know Sarah and her daughter over time, one of the other things that I just want to add and maybe invite you to make a little bit of a comment about, like, this is also a child who has the most amazing singing voice. And when it's time to perform, is like at the center of the stage. Or I should say a young adult. And so, some of what I think we want to bring in and we really want to focus on is how do we help individuals, as children, before like preventing FASD, but then also across the lifespan, to build in those supports so that they can spend as much time singing. And what are those supports needed? So that's a lot of what we'll really be talking about today. I think it's a beautiful way to kind of set our context. I want to invite Beth to share a poll with you. Just some of you have also talked in the chat box. We do have another person who is a parent of alcohol and drug impacted children. We also have people who are home visitors, case managers working in family-centered treatment, who are really aiming to know more and learn more during the session. And let me invite you all to tell us a little bit more in terms of the logistics of who do you work with? And you can check all that apply, just because it gives us a little bit of a sense of who's here in the room. I'll take another minute. Okay, so we see, and I'm going to save time and not actually share the poll results. But almost 70% of the people here are working with pregnant individuals. So that's part of the context that you're bringing in. 6% with parents with FASD, 13% with parents of children with FASD, and then 13% also, I don't know if anyone who I work with have FASD. So this is definitely the right webinar for you to be in. And I think just kind of getting us started, this slide is a fairly current slide. It says about 1 in 7 pregnant people in the United States report drinking alcohol, and 1 in 20 pregnant people report binge drinking in the past 30 days. So, the problem of alcohol does continue into pregnancy, and we get a lot more attention, a lot more resources that are really honing in, particularly around opiate use disorders in pregnancy. but it is important for us to pay attention to alcohol. And I'm going to invite Dr. Kathleen West to set the stage and give us a presentation around some of why is it so important? Why is it a problem that so many pregnant women are drinking during pregnancy? Kathleen.
Okay, thank you, Deb. This, as Deb said, this is an issue that really persists. Alcohol use disorder is quite prevalent, as that previous slide indicated about pregnancy, but it's even more common across the population. And I think we tend to focus on the illicit substances, as she said. The opioid epidemic, stimulant use disorder, methamphetamine and cocaine are still big challenges and are growing across the country. So alcohol just seems not very interesting to talk about because it's legal, it's ubiquitous, right? It's at which means it's everywhere, right? It's at all of our social events. It's marketed, openly, obviously on television, and it's been legal and used in many circumstances, forever. So it is a drug, and it is also a teratogen, which I'm going to talk about a lot, which is why it's relevant to know about it vis-a-vis pregnancy. And it is a teratogen is something that you may have heard of back in the day. When people were talking about thalidomide, if any of you have heard of that phrase, it was a drug or that name of a drug. It still is used for treating cancers, but it's used extremely carefully, and it's actually illegal to prescribe it to a pregnant woman. But it was used to quell morning sickness, nausea, in early pregnancy. And in the 60s, and late 50s, it was used a lot. It seemed like a great drug. However, it caused massive numbers, thousands and thousands of babies were born with limb reduction, which means they were born oftentimes with sort of like flippers, or it caused a lot of other cellular defects. So a teratogen is something that causes changes at the cellular level. It's not at an organ level, it's actually at a cellular level. It causes what we call dysmorphology. Morphology means shape, dys means to change or to make wrong. So it causes a change in the cellular structure. And so it's right at the very, very most fundamental element of how we're all made, what we're all made up as. And each cell has its own purpose, and each cell has to work with other kinds of cells in order to create a kidney or a liver or a differentiating from an embryo all the way to a fetus and then to an infant. And so it's really worrisome that alcohol is the most frequently used drug, because people oftentimes don't know that they're pregnant. But alcohol is used with most other substances as well. It's oftentimes used with other drugs to titrate the effects of those drugs. It's a disinhibitor. It is it's actually a depressant. And it probably accounts for many, many, many psychiatric diagnoses that are misdiagnoses over the lifespan, including attention deficit and hyperactivity disorder, attention deficit disorder, ADD, ODD, borderline personality. Many of these things are, because it's a behavioral teratogen as well, which we'll get into a little bit. But it is also the leading cause of preventable intellectual disabilities in the developed world, and probably in lesser developed countries as well. South Africa has a huge population of children with FAS, as does the Soviet Union, as does Romania. There are some entire places where the entire population has fetal alcohol spectrum disorder, some sort of ill effect from the presence of alcohol. And it is it's ubiquitous. Alcohol is also actually involved in those cases of domestic violence. So it's definitely a drug that we need to be concerned about and address it as a drug. So I wanted to just give you that background to start out here. When we talk about fetal alcohol syndrome, it is a syndrome, which means that it has a certain number. If you look at DSM-5 or any other medical textbook, a syndrome is something that has a collection of characteristics that all kind of have to be ticked off in order for it to meet the criteria of a full syndrome. And so what originally was described as fetal alcohol syndrome was actually first described in France by a guy named Lemoine, and then almost simultaneously described in the 70s by David Smith in San Diego, and then subsequently Anne Streiskuth and her work at University of Washington, came along. But the reason I mentioned where it was identified is because we sometimes think, oh, well, the Europeans know how to drink, right? They can drink their, their wonderful Burgundy wines with, lunch, and it has no ill effect and there are no problems. Well, wrong. Wherever you are, there's a high incidence of fetal alcohol spectrum disorders in France and Europe. It doesn't matter. It's not like you can just drink it culturally and necessarily not have any effects. So what we look at when we see prenatal alcohol exposure, interestingly, you'll see there, one of the things here says no effect. There can also be, I'll get to that in a minute, but fetal alcohol effects, what used to be called FAE, and now we're sort of changing that up a little bit. Fetal alcohol syndrome is when it's really the full-blown characteristics and death. So you go all the way from no effect to death. How can that be? One of the variables in that is genetic predisposition or genetic vulnerability. And I have actually been at deliveries where we've got two non-identical twins, one born looking very much like they have the full facial characteristics of a FAS child, and the other one having no apparent effect at all. Death is probably a very, very likely outcome. Many fetuses, as Sarah has described, probably die in the first couple of months if there's alcohol on board by the mom. So it causes spontaneous abortions, and it oftentimes happens before the mother even is aware of her pregnancy. So it may be when you are still dealing with an embryo. A lot of alcohol will kill it. So what we used to call fetal alcohol effects then got broken down into fetal alcohol-related birth defects, which is a very big catch-all, but it mostly relates to the physical kinds of things that you see, not the neurodevelopmental issues. So there are other kinds of problems that happen across a lot of different organs, but then the one that is most affected, that we most notice anyway, is the brain, because we'll get to that in a minute, but it continues to develop, change. The central nervous system changes from the very beginning all the way to 40 weeks of a full gestation. So ARND, as it was called for a while, and is now sometimes called, FAE is also, as it's noted there in the chart, is sometimes called partial fetal alcohol syndrome. So there's this whole spectrum, and that spectrum ends up being called FASD, and it's oftentimes really what we're working with when we're dealing with this group of folks. So it can have lifelong effects. As I said, it was first, actually I misspoke, I think at 71 or 72, but it was 73 apparently. It is now more recognized by the medical community. It's still not taught that much in medical school. You don't get a lot of time spent on addictive disorders, or certainly not on alcohol either. But it is more recognized today. And what we know also is that it does create increased susceptibility on that individual's part to becoming chemically dependent, especially with alcohol. And I will get to that in a minute. But they may also have a predilection for various reasons to becoming chemically dependent or addicted to substances. And it is related to a range of learning disabilities and behavioral disabilities or behavioral challenges. And again, as we saw here in the poll, many of your clients may be in this boat of being undiagnosed with a fetal alcohol spectrum disorder. I want to just throw, I realize this is not an embryology class. This is not a a class to teach you really about gestation. But why I mentioned this is that you see that the central nervous system, the brain and the spinal cord are developing throughout the entire full period of pregnancies. But a lot of it is happening at the very beginning, and you have at different times of gestation, there are different organ systems that are particularly vulnerable to teratogens. It happens that the brain is pretty much consistently vulnerable. So right about in here, when you begin to have about 16, 24 weeks, the fetus begins to actually drink amniotic fluid. The kidneys get started. They begin to drink. They begin to, get geared up for functioning externally, and not being dependent on the maternal environment, the womb, to sustain life and to be able to work. So what begins to happen then is that the entire organism of the baby, the fetus, is affected by what they take in. So they begin to actually develop an intrauterine tolerance to the substances they're exposed to in the womb. They also oftentimes, as I mentioned, domestic violence often happens in these cases, and it often happens during pregnancy. So if the fetus has other kinds of what we call insults, other kinds of things that it's exposed to, like getting the mom's getting hit in the abdomen, that can be shocking. The mother's having a high rush of adrenaline, epinephrine, is upset, is anxious, has all sorts of things going on. Then we see that that fetus is affected as well. And sometimes a lot of alcohol consumption on the mother's part is accompanied by other kinds of behaviors on the mom's part, which can be problematic. So sometimes we know that a baby or fetus will, babies typically have their first bowel movement after birth, but a lot of these fetuses, fetal alcohol exposed fetuses, will have their first bowel movement while they're in the womb, and that's called meconium. Some of you may know about that, and sometimes when a fetus is passing through the birth canal, they take their first breath, they gasp, and they take in the meconium, which sets up an upper respiratory distress infection. They oftentimes end up in the NICU. There are other kinds of problems, things that definitely are happening that cause problems. And this is way more common. All of these things are more common in a fetus that is exposed to alcohol during pregnancy. So why we miss a lot of these cases at delivery, because you don't have the full facial features. They're hard to recognize. And I'm just throwing up this slide, even though it's showing us a diagnostic guide for FASD in 2004. So we've been doing this for a really long time. And basically in the past, you needed to use anthropometry, using a little basically measuring tool to figure out facial dysmorphology, changes in the facial structure, other kinds of things, the ears, the hands, the creases on the interior of the hand, all sorts of things that change, don't look the same in a fetus that's exposed to alcohol. But if you look at this, the chart here from 1 to 5, this is just one of the features where you have a thin or a non-existent philtrum, which is this little crescent between your nostril and the upper part of your lip. But what we see is down here is this is a normal, a healthy individual, non-exposed individual. And you go all the way up and you see that it changes. But this whole spectrum is on spectrum. This is a frank FAS case here, but this is what you see in between. So it's really pretty hard to figure it out. And there are all these various ways that we've worked to try to do it over time, but it hasn't been totally effective, and it really requires someone trained in order to do it. So to get a really good diagnosis, you really do need to, or you did need to go to somebody that was really skilled in this, and there were not very many, as Sarah described. This is a an example of a cute little baby, right? Who actually has fetal alcohol syndrome. And so as a young adult, you don't see, looking at that, you wouldn't really, decide that, on observation that you had a case necessarily that you would work with. However, if you're working with when I worked at Martin Luther King, we actually did have a lot of Fasd co-occurring with, at the time it was crack cocaine. But I happened to work with a perinatologist, Excelina Bean, who's fabulous, and she would eyeball the kids and be able to say, and this is what I'll tell you what she said. She said, and this is used across still today, it's still used in OBGYN circles. It started out, I think, in Europe, but she would say, oh, we've got a couple of FLKs upstairs. And I wonder if anybody can put in the chat, does anybody know what an FLK stands for? Does anybody know what that diagnosis is? Yeah, you got it, Jean. Yes, that's it. And they would say, we've got a funny looking kid. And it was like you couldn't quite put your finger on it. You didn't know quite what you had, but it was a indicator to basically do some screening, find out. This was oftentimes a mom that didn't have prenatal care. You didn't really know what the pregnancy history was. But if you could validate that there was a history of exposure to alcohol, then you could begin to look at, where were we really going with it? How could we start intervention soon? How we could get the mom to treatment? And that was one of the goals that we really worked with there. So, as I said, we have this whole spectrum, and oftentimes we miss the cases that are not a full-blown FAS, and we may miss it even if they are. But more recently, in 2013, people realized that the prenatal alcohol exposure period causes this neurobehavioral disorder. So this is now called neurobehavioral disorder associated with prenatal alcohol exposure, and it is probably the kind of biggest catch-all. It's considered a condition that's under the umbrella of FAS in the DSM-5. And so what you see here is if you don't have this full-blown experience, you can see major changes in cognition. Poor judgment is one of the probably biggest features. Inability to retain information, not adaptive functioning. So if you know how to do something, or you think you know how to do something, that may be variable. But you also may not be able to, if your environment changes, you may not be able to change quickly enough to figure out what's going on. For example, if you're told that you need to wait at the bus stop to catch the bus, you may just sit there in a snowstorm if the bus doesn't come because there's a blizzard, and end up with hypothermia. That kind of failure of adaptive functioning. Self-regulation challenges can be there. So this is something that is a diagnosis that is increasingly used, and is used oftentimes by mental health professionals in order to be able, when they can't quite figure out what's going on, and in order to be able to generate interventions and support for the family. So this is an update on, fetal alcohol syndrome. I just gave you some, all the background, but I hope that's helpful for folks to understand sort of what's going on with FASD. But instead of needing to use anthropometry now, we're really using new imaging tools that really help when you're dealing with the teratogenic effects of alcohol. It doesn't address the neurodevelopmental kinds of issues, which are more behavioral, but you can begin to see now with imaging tools where somebody is falling, and this is a healthy case. This is a partial fetal alcohol syndrome, and this is a full FAS. So you see that there are differences in the facial features that we can note. And one of the reasons why this is really important is because we have missed many of these diagnoses over time, because most medical textbooks are normed on Caucasian populations. And sometimes some of the features of a person with FAS is for example, a flat nasal bridge, different palpebral fissures, which are the eye openings, different kinds of chin formations, different offset of the ears, are some of the characteristics. I'm not, going to go into great detail, but some of those would be characteristics of an Asian Pacific Islander, for example, with a flatter facial structure across here or a flatter nasal bridge. So we would miss it because everything was being normed on a white population. So this has really helped, this imaging tool, because it's been done across culture groups and across races and ethnicities. And so it's been really, really helpful. And I just want to say that we've got about, as we said, about 20 to 30% of people have reported drinking during pregnancy, 8% have reported binge drinking, 10% report drinking in the previous month. It's a fairly high percentage. That's interesting information, but what I have found really helpful, and I'm going to tell you right now, this chart is 2003, 2004. Because they're no longer collecting this information routinely, which is really a shame. For those of us that are interested in the details on this, first trimester drinking is where it's at. That's where you're going to see the biggest problems emerge in terms of a full-blown teratogen with cellular structure changes that are not able to be remediated. There's nothing you can do about it. But what I also wanted to point out in this, which is really encouraging to me, or I see it so, is that you see that a lot of people in the first trimester were drinking, and it dropped dramatically by the third trimester. Now, this is not necessarily the same individual, but what we really saw was that when education is provided, people really reduce their binge alcohol use. They reduce their alcohol use overall during the course of their pregnancy, and stopping or reducing use at any time is very important. And that's true for illicit drugs as well. So it's just really important to recognize that we can do a lot to encourage people to get into prenatal care, really to educate them about alcohol. It's not just the illicit drugs they need to worry about. Frankly, they are less harmful. There's a lot of remediation you can do with cocaine and heroin exposure. The fetus and the body will recover. That is not true, period, not true with alcohol. It's irremediable. So what we recognize too is that this is intergenerational, and what we see here is a lot of toxicity with the uterus. There would be some times when we actually had a mother go into early labor, and we were aware that she was drinking, and the question was whether we would stop the labor and basically let her go to term. And very often the decision was that the uterus was so toxic that it would be better to get the fetus out and have them in the NICU. So you have the intrauterine toxicity that can be there with alcohol. It definitely affects the way the baby is then delivered. They have increased muscle tone, be really rigid. That means they don't mold well when you're holding them. They can be really irritable, fussy, don't feed well, they can't suck. And that puts them at much greater risk for neglect and abuse. They are not easy kids to care for. We can't be blaming the victim here, but they are, or the individual that's affected, but they are really difficult to care for. The mom oftentimes is not alone in this, right? There's this whole intergenerational issue. Dad's often got issues going on. The extended family may have a culture of use. There may be intergenerational issues, and there's biologic vulnerability to some challenges for the youngster growing up in these environments and then being exposed to drugs and alcohol and the genetic variability as well, and susceptibility. So I just want to mention this very briefly, and then I've come to the end, you'll be relieved of all these didactic stuff here, is that perinatal drug, which means during and immediately after birth, definitely causes stress and trauma, and it affects the whole neurological functioning and vulnerability, as I said, to substance use disorders in that individual as they grow up. Part of why that happens is because of a field that I work in is called epigenetics. And it's really the area where what we know is that exposures to certain substances will cause genes to turn on. So somebody may become more vulnerable to those to exposures and then to engage in use. I can talk about that later if you're interested, or you can just Google it and learn a little bit more about it. But what we basically, the gist is that this is a challenge that we're dealing with ongoingly. So thank you, and I'm going to turn this over to my colleagues, and I'm happy to answer questions at the end. Thank you so much.
Thank you so much, Kathleen. Really did a great job of setting that stage and breaking down a lot of the sort of what is really happening when we're talking about FASD. What does this really mean in a biological sense, as well as some of the broader social pieces that oftentimes we think about. All right, so here is a poll question for everybody. Beth, if you can bring out the poll. This is, you could call this a listening test. The leading cause of preventable intellectual disabilities in the United States is attributable to, you can only pick one, congenital, fetal teratogen, poor maternal nutrition, or childhood vaccinations. All right, look at us go. Everybody heard you, Kathleen. Fetal teratogen exposure is the by far winner. A couple of people are pointing out that maternal nutrition is also significantly problematic, but in the United States, the leading cause of preventable intellectual disabilities is actually that alcohol exposure that we talked about. And I'm going to go ahead and close it because we don't really need to share the poll results. I kind of already told you what the poll results are. And start to switch gears a little bit from some of this overall conversation about what is FASD, why is it important that we intervene? And, one of the things that Kathleen mentioned that I just want to restate is that stopping or reducing alcohol use at any point along that pregnancy continuum is important, right? So, and of course, it's going to be the earlier, the better. And let me invite Candice to share some of her experience and her thoughts around what are some strategies that we can really prevent FASD, some of the engagement for pregnant women. Candice.
Thanks, Deb, and thank you, Kathleen. I am a neuroscience nerd myself, so actually I was really in tune with that entire conversation, so I loved it. But I kind of want to switch gears and talk a little bit more about how we can really improve our capacity and our services. As Kathleen and Deb said, pregnancy or awareness of pregnancy in individuals is the best time to stop in terms of alcohol use, misuse, substance use, and often that period is missed. When an individual learns that they are pregnant, typically they are told to stop drinking entirely, or they will take the initiative to do that. But when you are dealing with an individual with alcohol use disorder, likely they aren't able to stop of their own accord. So learning of pregnancy is probably the perfect time to actually step in to provide intervention or any sort of supports that would then support them as they are unable to stop of their own accord. However, this kind of period is often missed or not utilized. And I want to talk a bit about SBIRT. So in the chat, as I continue moving forward, and I will also be dropping some links into the chat, I would just love to know if anyone here already is aware of SBIRT or utilizes SBIRT guidelines in their practices. So again, just continue to kind of maybe make note of that in the chat while I continue moving forward. Oh, I already see some really exciting answers. Perfect. So I will actually just drop this link in the chat just in case folks do not know what SBIRT is. SBIRT, as Deb already typed, is screening, brief interventions, and referral to treatment. So when we talk about screening, we're talking about actual screening tools. There are quite a few already out there when it comes to alcohol use disorder, but there are a couple that are a little bit more recommended when working with pregnant women who are using alcohol. And two that do come up are the TWEAK and the TA. So I'm actually going to drop a couple of those in the chat as well. Normally, these two tools are used for screening for heavy substance use, or moderate to heavy substance use, which is typically great after you have already identified the individual as drinking fairly heavily. But what these tools do kind of miss is checking for any current drinking. So again, I want to kind of go back and reiterate that often when a woman learns that she is pregnant, she is told to stop entirely. So these tools may not actually capture if they are still currently drinking. So you may want to think about when incorporating screening tools, maybe utilizing something like these two tools, but also maybe creating or developing a tool that checks for any sort of drinking. It could be, a very brief period, intermittent drinking. So we just want to kind of capture that piece. And I think that is kind of missed when screening for any sort of drinking periods while women are kind of checking in with their pregnancy. So brief interventions are typically interventions you can use to kind of prevent any sort of continuous drinking. I love to kind of wax philosophical about motivational interviewing. I'm really passionate about it. So if you are someone who's aware of motivational interviewing, it really is a type of intervention that encourages the individual to kind of use their own motivation to stop any sort of behavioral issues. You're using things like open listening, reflective questioning, summarizing, kind of getting the individual to really look at their own behavior, understand the purpose of why they're doing it, and find motivation to kind of move forward to stopping that behavior. So kind of incorporating some sort of counseling that uses techniques like motivational interviewing or cognitive behavioral therapy to kind of help support the individual to stop drinking is where you want to kind of pull in that brief intervention piece. So if you're not already trained in that, it is good to maybe kind of incorporate counselors or find ways to become trained in things like motivational interviewing. And then if it's actually needed, referral to treatment or referral to specialty substance use disorder treatment programs is, of course, the key in terms of making sure that the pregnant mother is receiving treatment. Kathleen will probably go a little bit more into about what sort of treatments are out there in terms of MAT for pregnant and postpartum women who have alcohol use disorder, but there is a lot of developing treatments out there, some kind of back and forth about what is and what isn't working. So Kathleen will go into more about that, but that is what we're talking about when encouraging referral to treatment. So ESPER, why is it not necessarily utilized? There are a lot of reasons, but mostly there's some kind of adherence to first incorporating guidelines into your practice and services, and also some kind of adherence about policy, reimbursement, number of typical reasons. But really comes down to lack of awareness, inertia, whether you might not be able to get reimbursed for incorporating experts, lack of time. So I said there is kind of a pretty brief time period between catching the mother as she is engaged in alcohol use, and then also getting them in the door to the treatment and screening. It's hard to, especially if they are of a population that may be transient or homeless, or they may not have connections to services. It's very easy to miss the perfect time period to screen them and get them into the door into treatment. There's also a lack of knowledge about screening and referral, and a lack of knowledge about interventions that actually may be supportive in helping support pregnant individuals. So there are a lot of reasons why there might be some adherence to not actively using ESPER. I think one reason that is not discussed enough is there's still a lot of stigma around pregnant and postpartum women who are using alcohol. There's a lot of stigma around individuals who use alcohol in general. But I think when it comes to individuals who are pregnant, that stigma is still very prevalent. And that may kind of lead to doctors or treatment specialists who may not want to disclose a mother's pregnancy and alcohol use in case that could lead to very messy situations. As we all are aware in this country, there is a lot of stigma that may lead to incarceration when it comes to pregnant women who are just using substances. And so there might be some iffy feelings about wanting to disclose that as they screen a mother who may be going through the doctor's office. So there are some interventions that you maybe can employ or techniques to kind of start to think about how we can get ESPER more involved in our practices. And I think one of the easiest, I wouldn't say the easiest, but I think one of the best ways to kind of start off with is kind of having interventionists. That means maybe engaging women who are going to clinics, OBGYN offices, and even thinking about places like Planned Parenthood or kind of community clinics where they're going to check to get treatment, and incorporating folks in there who can do screening at the time. So whether that is you are training folks in those offices to do that screening in primary care offices, or you are already kind of creating some kind of referral system where they can come to you to get that screening, that is kind of where you want to start first. So I think in any case of expert, you always want to think about an entryway or a pathway where they can be engaged and then get immediate screening done. Because again, there's not that much time in between getting them screened and then getting them into treatment. So it might be best to start off at some kind of clinic where they're already going and having that screening be done there so they can immediately go into treatment or get some kind of intervention done. Of course, we want to think about educating our providers. There's still, again, a lack of awareness of why experts important or what may work with pregnant and postpartum women when it comes to their alcohol use, or even just understanding the nature of FASD and why, again, we want to prevent it right at the very beginning of pregnancy. So educating providers, which many of you are already here doing that, which is the very first step, is where you want to also start about as well. They're also getting use of things like incentives, maybe thinking about how value-based purchasing or other ways to make sure that you get reimbursement for using expert. But those are, again, ways you want to think about incorporating that. And then there was one other option that I actually did research on that I thought was very interesting, using time reminders. So I think when it comes to screening, it's very difficult to think about, again, time, screening at the very beginning, and then screening at maybe a 6-month period or a 12-month period. So maybe incorporating time reminders to remember to go back and to do another initial screening with a client that you're constantly checking in on their substance use and where they're currently at in their alcohol use disorder is an important piece in making sure they're constantly kept up to date in terms of their treatment. Finally, looking at your own sort of practice and services and making sure that you're actively engaging in some guidelines for experts and maybe incorporating performance measures to make sure that your service and practices are up to par with expert in the system. So we want to, again, take a look back at where our practices are. Is expert really kind of incorporated throughout our services, or is there sort of some guidelines in place to make sure that we are engaging in screening interventions and have a referral pathway to treatment? So that is just my little spiel on where expert comes in to preventing FASD. Again, I hope most of you are already kind of employing it, but if you aren't, hopefully looking into ways to kind of incorporate it into your work so that we can really aid in kind of getting this population in the door and continue with the treatment and recovery supports. So I will end it there and pass it back to Deb.
Candice, thank you. And I think that was a great explanation, thinking about expert and some strategies that you can use to really make sure that we are using expert to identify pregnant women and alcohol as early as possible, and then provide some of those interventions. Like alcohol use occurs kind of on a continuum, right? So those brief interventions, they're going to work for that episodic, periodic, social person who is drinking alcohol or binging. But that woman who has an alcohol use disorder, that's probably not going to be sufficient for her to successfully stop drinking. So, thinking about that whole continuum of doing the screening so that you're identifying and engaging, and then being able to have those different types of services that will meet people where they are. So important. Kathleen, let me invite you to come back onto camera and add to this conversation around preventing FASD.
Yeah, well, I think I absolutely agree with everything that Candice just shared, and you're absolutely right. And as I mean, it's never too late to intervene, and it's really critical to get that information out. I mean, I think that we need to also be educating the healthcare professionals that are not as alert to this. And we still have, care providers that say, if a woman says, well, I was drinking over the weekend or whatever, people tend to underreport. So if they say they had 1 or 2 beers, and they say, it's not a problem, people still say it'll let down your milk, it's good for the, for breastfeeding, whatever. So there's a lot of, don't assume that the people you're working with necessarily know what you know about this, and that it's important to make sure that we are doing the interventions when we can. I think expert's a great tool, and we need to also advocate for changes in the sexism that we see in our substance use disorder treatment programs and our alcohol use disorder programs. They're not necessarily always sensitive or supportive of women. So I'll just say that I hope we can use compassion and support versus judgment and anger. It's easy to get angry at the mother. I know when I work, I think the folks I worked with in the NICU were were very, very angry. They were not maternal child health professionals. They were either like on the mom side or the child side. They really couldn't wrap their heads around. They were so mad at the mom, and you get it. It's an emotional response, but these women typically feel shame, fear, sadness, just depression, have a lot of issues that we really need to support them for. So, I'm delighted that Candice has shared that good information with you all. I hope we can apply it.
Thank you. And Sarah, would you like to add anything around this general conversation around preventing FASD?
Sure. Again, I'm not on the clinical side, but one thing that is showing some promise, there's still clinical trials around it, but is adding choline supplementation. It doesn't cause any bad effects, but it can mitigate some of the effects on the fetus and help lessen the effects after the fetus is born. If the mother's not going to stop drinking, at least I would say try to get her on the choline supplementation and read a little bit about how that can help out.
Thanks. I think that is an important piece. And I wonder if you or Kathleen could add something to the chat around sort of a link to some of the research on what that on the.
I will do that. There is going to be a randomized clinical trial that's starting to recruit this fall, and there have been some evidence. So I'll put some of the references in there. So thank you for bringing that up, Sarah.
Thank you. And so this is where we come up with our hybrid, right? So these are some of the key takeaways. A lot of this you've actually heard within some of our panel presentations, and some of it I'm not sure that you've really heard. I did put a question into the chat, inviting you all to talk about and share some of the different strategies that you are using. I see Cindy is talking about starting with underage drinking prevention initiatives, and I invite you all to continue to do that in terms of the chat. And that really goes right to this very first bullet, that alcohol education and awareness of risks prior to pregnancy, like at the Planned Parenthoods, making sure that women and girls who are in that 15 to 44, or maybe I should say 10 to 50 kind of age range, that this conversation comes up. Because as Kathleen mentioned, that first trimester and binge drinking in that first trimester is one of the most vulnerable periods. And oftentimes people do not even know that they are pregnant. So with people who are planning for pregnancy, yes, a lot of pregnancies are unplanned, but people who are planning for pregnancy, building that in so that they are intentionally starting with as healthy of an environment as they can. And then also, as Candice was talking about in terms of screening and brief interventions, alcohol education at that time at prenatal appointments is a really important piece of that, making sure to be able to have those conversations. Now, I'm going to say that, but I'm also going to say that you want to do it carefully, because if you're at a prenatal clinic, one of the most important things that you want is for people to keep coming back to the prenatal clinic. So that avoiding blame or shame or guilt, or what I think it was Kathleen was talking about having compassion, really, really important in how you engage those pieces. Not making an assumption. Also, for those people who have a dependence on alcohol, who aren't able to stop, you really want to make sure that when you're giving that education, you aren't forcing them into shame and grief and fear that's going to make everything worse. It happened to be that last night I saw on a news brief a piece around TikTok and Instagram and some of the other social media piece that was sort of framed as preying on pregnant women. That part of what is happening is that pregnant women are getting information about stillbirths, and all of a sudden some of the educations around dangers of getting the flu, or education around dangers of this, and the algorithms are identifying them as vulnerable. So they're getting bombarded with a lot of different information that really fills them with fear. Now, it's important to get the education, right, and to know things, but part of what can happen is getting too much of that without some of this is a low risk is also important. So yes, binge drinking in the first trimester is not good. We want to avoid it if at all possible, but we also don't want to have that person who did binge drinking in the first trimester say, oh, well, I may as well keep drinking, I've blown it, or live in absolute fear and terror and anxiety, because we know that fear, terror, and anxiety do not promote a healthy pregnancy either, right? So building in some of those kinds. So alcohol education and awareness, expert, active engagement into evidence-based treatment and recovery services. One of the things that Candice mentioned is with expert, one of the reasons physicians often don't want to ask about alcohol is because they don't know what to do if somebody says, yes, I have a problem. And this is a very important rare window time, right? So being able to have that interventionist or that person or that automatic linkage with somebody who is delivering services for pregnant women to actively engage that woman and help her be able to identify strategies and engage in some of the evidence-based treatment recovery services that you all are providing is really important, right? And that kind of work, I know somebody is a home visitor, somebody is working with care coordination. Sometimes it's just talking, engaging in some of the cognitive behavioral therapies and DBT, all of these things really, and ideally some of the comprehensive services for pregnant and parenting women to help them to be able to, because it's not like pregnancy is really important, but post-pregnancy, we also want healthy moms, right? So building in some of those supports, because not everybody can just kind of white knuckle through. So active engagement into those treatments. This also talks about one of the reasons we really need to engage with those is, for the most part, alcohol medications for addiction treatment for alcohol use disorder. There is not been enough research to indicate whether any of them are appropriate for women during pregnancy. So any physician is going to be doing a serious risk benefit. And some are definitely counterindicated. And also often we know that alcohol and depression and anxiety can go closely together, and they may also be having to make adaptations to their psychotropic medications. So again, really building in the supports that people need. I think Kathleen, I think we've all talked a lot about avoiding blame or shame and focusing on strengths. And then that piece that it isn't just about the alcohol, having a safe place to sleep, a safe environment, taking the vitamins, all of those things are also very important in terms of creating the healthiest possible birth. And then I like also conversations that talk about the fourth trimester. So ensuring that people have those continued supports after the baby is born. And this also includes strategies around breastfeeding, because if somebody is drinking heavily, then there is alcohol in the breast milk. And so paying attention to those things. Carol, I just want to call out a thank you for your chat and your honesty in the message around the importance of preventing that shame. And I want to just thank you for being an advocate for your daughter and for, I'm betting, tons of other moms and experts in treatment. So thank you. So that kind of gives us our pieces around, we really want to reduce the impacts of alcohol. One last statement about that is, again, because methamphetamine is getting a ton of attention. I don't know if you all are aware of this, but if you're using methamphetamine, you can drink in huge quantities of alcohol, and the two just go together beautifully, right? So making sure that we aren't just addressing the methamphetamine, but we're also addressing the alcohol. Same is true for opiates. Is that we don't want to just focus on opiates and leave aside some of these other pieces as well. So with that, I think is a good kind of summary. Let me just see if anybody wants to add, Kathleen, Candice, Sarah, if any of you want to add a burning comment to there. Otherwise, we'll go into a discussion around supporting the infants across the lifespan.
No, that was great, Deb. I'm really glad you mentioned though the fourth trimester. Is that, sometimes, all too often actually, if the Child Protective Services removes the child from maternal custody, all of a sudden we think we've solved the problem, right, in air quotes, and let the mother just, we don't care, how what's going on with her. And I think we need to just make sure that we're providing, good care to that whole family, whatever that dynamic is. So yeah, thank you for mentioning that.
Great, thank you. So let's move into our next area, and that is supporting infants and children affected by FASD. And then I'll save a little bit of time for this actually to talk also about adults who may be pregnant who have FASD, whether diagnosed or undiagnosed. Sarah, why don't you kick us off? What are some of the strategies, that have worked for you? Some of the strategies for supporting infants and children.
Well, I got my daughter at age 5. So the infant part, I don't know as much in terms of lived experience, but once you have these children, they're going to struggle most likely their entire lives, and getting them into early intervention is incredibly important. You need a neuropsychological evaluation. You need a psychological evaluation. Also, there can be major auditory and visual processing issues with FASD. So you want both of those evaluated so people know what they're working with. You know where your child has the gaps, and you know how to help them early on while the brain is still developing before it gets to the point where the patterns are set. Often with these children, the left side of the brain and the right side do not connect because of the way the alcohol impacted the brain development. So there's no ability to have abstract thought. You need to make everything incredibly simple for the children. With my daughter, I found that my language was always too high. I needed to simplify everything and only use very short sentences, because it's kind of like having ADHD, which I have. After the first 2 directions, I've lost my child. Even at age 28, she will not remember anything. So it has to be simple. I need structure. They thrive on that structure because time does not make sense to most people with FASD because it's an abstract concept. So the past and the future don't really make sense to them. And so everything, they need to know what's going to happen when, to avoid kind of confusion and meltdowns. So I found that when I structured my home in a way that is not me, I'm very spontaneous, but I had to be incredibly structured and have time frames for everything and let her know what was going to happen tomorrow. And schools had to do the same thing. I had to teach everyone who worked with her, because everything, like it says in the comments, is black and white. There's no gray with my daughter and most of the friends she has who are FASD. If she goes to a doctor and they say, how do you rate your pain on a scale of 1 to 10? That's like saying, how do you rate your pain on a scale from zebras to giraffes? It means nothing to her. So she just looks at me. I say, that doesn't make sense. It's just ask her how much, how she feels. Even things like time doesn't make sense. They're just numbers. Math doesn't make sense. If you give her $100 bill or 10 $1 bills, she'll take those $10 $1 bills every single time because it's more. And so even when they get to be adults, she'll go to a fast food restaurant and give them money, and they give her change. They gave me money. If they weren't honest, they could take all of her money. There's such a vulnerability there. So teaching them and repeating over and over again these concepts, because with FASD, it's what they often call Swiss cheese brain, where one day they know the concept, they know it beautifully, they can repeat it to you. The next day, it's as if they've never heard it in their entire life. And then 4 days later, they remember it again. And it's incredibly frustrating to teachers. And they think the kids are doing it on purpose sometimes, and then they end up getting lost in the system. And so, the big ones for me is a CCRRSSS is how I like to think of how I work with her. The 2 C's are be concrete with everything and be consistent. Don't change things around. The R's are repetition, routine, and the S's are simplify everything, provide structure, and always give supervision, because these kids and adults are so vulnerable. If you ask my daughter to run with her friends and jump off a cliff, she will do it because that is what her friends want her to do. And they get left behind as their friends grow up and become adults that are so desperate for friends and to fit in that they will do things they wouldn't normally do, and which is why they so often end up in jails. So I know that was a lot of random stuff together, but really just remember their brains are not like most people. It's black and white.
Thank you. Kathleen, anything you want to add? Or Candice?
Sure, I will step in very quickly. So I actually kind of will end up piggybacking off of Sarah because I think she really mentioned some important details that kind of go along with kind of what can help support an infant or even a young person or a young adult. So adaptive skills training, kind of what Sarah was mentioning, is that there are things that are lost in translation for an individual with FASD. They may want to kind of incorporate tools that can build skills such as communication, safety awareness, which I think is actually really important. So maybe being able to understand what certain tones things mean, understanding how to engage with an individual or what kind of certain behaviors mean. Also, I think with kind of some interventions, I don't know if there's a lot of research out there, but there is some research. So kind of piggybacking off of Sarah, I'm also ADHD. And so there is some research out there that stimulants might be able to be used to adjust behavior in infants or young adults or young persons with FASD. I actually was looking into it. I think it's actually pretty fascinating. So you may want to look into that. Also, there is some interventions for parents in terms of building their efficacy. So things like families moving forward, which helps to consult parental self-efficacy and helping to support youth who are engaging in FASD or have issues going forward with FASD. So that is also something to look into.
Thank you.
Yeah, I think that the parents oftentimes know more than, about what works than some of the providers because they've been living with it. And I think, as Sarah said, because sometimes they can parrot things well. Oftentimes they will repeat back, but they really don't have the comprehension sometimes. So typically they're assessed as being higher functioning than they are, which absolutely leads to vulnerability and absolutely can be taken advantage of, and that's true sexually as well. I mean, it's not like they're not developing physically. They can, enjoy sexual relationships. They can be in a relationship, and they can also, if it's a female, get pregnant or impregnate someone, and they need to be, as they age, we need to deal with their whole lifespan issues. And that's where another area of my reproductive epidemiology work comes in, is that that's a whole other population that needs special care and attention to those offspring if they happen. So thank you very much for sharing, Sarah. It's really, really very valuable.
One other thing that I just remembered, it's not out yet, but there is a group that is developing an FASD app for phones that people who have that can download it, and allows them to kind of structure their day, give them reminders about the things they need to do. And it's designed specifically for the brain, the way the brain works when you have fetal alcohol. And so that hopefully will be out in the next year or so. So that's something to look out for and to maybe share with your clients to help them with their daily lives and adaptive functioning.
Mm-hmm. I'm going to quickly share this key takeaways, but then I want to come back to some of the conversation that all of you have been talking about. So, we've had some of this conversation. I think all of these things were touched on by different ones of the speakers. The importance of that early interventions, and Sarah put some examples of some of the assessments that you're going to need as vital, and then also continuing interventions and supports across the lifespan. And I do want to emphasize that, especially because, Sarah's talking about her daughter has experienced extreme disability as a result of her FASD and some of her other early childhood complex trauma kinds of pieces. And there are also other people who have less of a struggle, but still have FASD, often undiagnosed. We've come to realize that when we're working with people in our criminal justice system, huge numbers of them probably have FASD, and so they are vulnerable. One of the ways that, this is somewhat of a sidebar, but one of the things that I really relate to is helping me understand part of the effects of FASD, although I would completely leave the why to Kathleen, is that it appears, we have that in 12-step programs, they talk about insanity is doing the same thing over and over again and expecting different results. Well, that really part of what that means is typically we learn from our mistakes, right? So you make a mistake and you say, oh, the stove is hot, I'm not going to touch the stove. That part of the brain and the executive functioning doesn't work as well with people who have FASD, whether they're, and it's developmental also. So that means that somebody with FASD, they have more difficulty learning, oh, I shouldn't follow my friends across that because it's dangerous, because they haven't built that kind of executive functioning muscle as well. But again, it does go really across a continuum. So some of the services, the parent education, specialized infant care, there's developmental services. I think Sarah mentioned some of the auditory and eyesight, psychosocial therapies, educational interventions and supports. There have been like specialized math programs which are being developed and tested, specialized strategies like the ones that have been shared around how we address some of the executive functioning. Always keeping the possibility of learning disabilities in mind, simplify and repeating. And, I think that that's important because sometimes in our programs, like we've come to realize that with methamphetamine, this is also true. You have to be very concrete. That it's often hard to take our complex concepts and build them into simple pieces, but that's really what works. And people are really good at faking it. So if they have no idea what you're talking about, it isn't just that they're trying to get something over on you, but they're not going to be freely admitting, oh, I have no idea what you're talking about, because I'm supposed to kind of know, right? So figuring out how you do those follow-ups, how you quietly reinforce those messages and check in on people's understanding so that things are built in. And then building also parent and caregiver education about lifelong risks and how to seek help. Respite if for parents, some of the education, some of those supports, and then the empathy and patience. So with that, though, I do want to turn to this question of when you have a pregnant woman who has FASD herself, or you think might have FASD herself, and she's coming to you and you're trying to engage her in services. What kinds of modifications, what should you be doing related to that particular pregnant woman? And invite the panelists to respond to that question.
I would think about it as if my daughter became pregnant, what would she need to know? She's great at nurturing. Those basic steps, like what time you would need to feed a child, what time they need to sleep, how you would get to do things. They need a very concrete list of things they can follow, steps that they can follow, because it's easy to forget things from day to day. Again, they might repeat to you, yes, I know I need to do this, this, and this, and this. And by the next day, they may have completely forgotten it. So having written things that are simple, because they may have an age, like my daughter's about like an 8-year-old in terms of her reading, as are many of her friends with FASD. So it would have to be very simple. And also making sure there's home supports, because once they get home, it's going to be overwhelming. And they often have a hard time regulating their own emotions. And then when you have a baby who's crying and screaming, I know my daughter's roommate, she's now in supported living, had a mother with FASD, and she was taken away from her because they'd be on a street corner and the little Irene would be screaming and crying, and her mother would become so overwhelmed that she'd just kind of stand there and look around, and then they'd call the police. And it's not that she didn't mean to be a good mother, she just didn't know all the steps and became easily overwhelmed. So really trying to pull on that parent's strengths and giving them very easy tips and home supports would be my suggestion for people with FASD who are going to have children.
And I'm just that's great, Sarah. All those are totally spot on. I'll just address what I think you need to do while they're pregnant. One is really reassure them. I mean, I have worked with individuals who are pregnant and they are terrified. There is a lot of fear. Their bodies are changing. They can be very, it really depends on, obviously. high functioning, which is but if they are, they can oftentimes be very, very afraid and don't necessarily accept the baby. They may have a really difficult labor and delivery for various reasons. So I think there's got to be a lot of support provided throughout, which we don't do very well. But I would really recommend that if we were going to do it well, we would really have somebody paying attention to and checking in with that individual around their eating behavior, their exercise, their mental health throughout the pregnancy itself to maximize the outcome for that individual and the newborn.
So I think I would just probably piggyback off both what Sarah and Kathleen said, just really having a space where they're fully supported. So one thing I did think was actually a good idea in terms of helping support is actually helping making a parenting plan. So that we can kind of, if they are engaged in substance still or, have FASD, just making sure that they know exactly what is sort of needed throughout the course of the pregnancy, maybe supporting them and understanding what is needed each trimester. So I think having a plan in place that you can then help walk them through would be a good next step in terms of supporting them.
Great, thank you. And then the other piece that just to mention, for those who are unlikely to be ending up keeping this baby, whether the baby is going to end up going to another family member and they'll have some involvement or is likely going to be removed, having the space to help them to understand and that they still want to be delivering a healthy baby and tending to that grief and the way that they're going to be tending it is also key important too, right? So, and again, it does occur across a continuum. So I don't want to imply that all people who have some alcohol exposure are not going to be able to keep their infants. That's not what I'm saying. But, building that, it takes a village, it takes a family, making sure they have those supports built in and that there's also honest communication. And I'm going to invite others to share in the chat other things that you're thinking about. I think Valerie just put in a piece that talked also about the importance of cross-system work and working collaboratively, which I think we would all agree with. And when we're talking about this, it crosses a whole lot of systems. It includes the educational system, as well as the health system, as well as the criminal justice system and the mental health system. And I think that's a perfect plug actually for our final poll. Secondary conditions found to be associated with FASDs include mental health issues, criminal justice involvement, risky sexual situations, alcohol and other drug use, or all of the above. Beth, do you want to pull up the poll? Did we lose you, Beth? There we go. And I'll invite everybody to just pick the answer that you think. All right, one more moment. And not universally, but almost everybody agreed that the answer is all of the above. And that would be the correct answer. FASD does contribute to, there's high correlations with mental health problems, criminal justice involvement, risky sexual situations, and alcohol and other drug use. So that's goes to the importance of that cross systems piece. I'd like to go ahead and invite, so this is actually a closing quote that is from somebody anonymous. Ask questions. We crave to be understood. It is one of the imperatives to a good life, being understood. And then Sarah, do you want to talk about the resource that we're going to be putting into the chat?
As I mentioned, I belong to many support groups online, and one is 7,000 parents. I asked them, what do you most want health professionals to understand about FASD? And I have 4 pages of responses. I would love if you'd read it because these are given from the heart from these parents and also from some people with FASD and a couple of parents who have FASD and also have children of their own. And they were very honest, very vulnerable. And I hope that you will read it and remember it as you work with them and to just have that empathy and push on their strengths, because they all have something beautiful to offer and they need to know that as well.
Thank you. And let me just see, Kathleen, Candice, do you have any closing thoughts?
I would love to end on this one final piece in terms of working with adults who may have FDIC and are pregnant, or just working with women who are pregnant in general, is that you make sure you incorporate harm reduction in all of your practice pieces. And we talk so much about, making sure that there's empathy and removing shame and blame, but also make sure you're meeting the individual where they are, so that your services incorporate harm reduction in every aspect, whether that is supporting the mother with breast pumping milk, or maybe having formula on the handy, making sure you're engaging, helping maybe the mother with child support care if they cannot keep the child or support the child, and that you just create a space that is safe for them so that they can move forward with their recovery in a way that can support both their motherhood and personhood. I will leave it there. And I'll drop a link in the chat to some good harm reduction resources when working with pregnant and postpartum women who have alcohol use disorder.
Great. I'm just the one thing I'm gonna say, and it kind of goes to Valerie's comment, is that you really need to take care of yourselves. So this is definitely the time when you put on your own airbag first before you help others, is that you absolutely have to make sure that you're practicing self-care if you're working with these families, because it's really difficult, and there's a lot of emotions that go along with it, and it just really is, it's exhausting sometimes. So I would encourage you to practice self-care. I guess that's all. And because we need you all in this field. Really grateful that you're here today. Thank you very much for caring. I appreciate it.
Great. Well, I want to thank our panelists. I also really want to thank Jean, our sponsor, for making this possible. And Tara Fisher, who has been working behind the scenes, making sure that these webinars came together and that we coordinated so we don't all say the exact same things, as well as our digital solutions team for the work today. I do have two other announcements. The third of the webinars will be on July 20th, and that one is really going to focus on reaching and retaining pregnant and parenting teens and young adults. So really focusing on what do we need, how are PPW services different when we're really working with adolescents. And the registration will be available in the link. And then we also are holding a summer PPW leadership learning collaborative that will be every other Tuesday starting August 2nd. And there's 5 sessions. This is something we also did last year. That will really be an opportunity to talk with your peers. There's with the application, which is a very simple application, there will also be a survey to identify what the topics are. Tara will be leading that, and Candice Russell will also be involved. Really nice opportunity to continue the conversations. And with that, I will just say a thank you to you all for all of the great work that you do. And we will go ahead and end the webinar. Oh, I have one more slide. We will end the webinar with the evaluation. Please go ahead and complete the evaluation. And you must fill out the evaluation if you want your continuing education credits. Thank you. And with that, we will close.